Hi and hello, Vitamin members. I'll take an immense pleasure in welcoming Dr. Rajashekhar sir as a teacher and mentor today. As a series of infectious diseases continue, so here is the next part of CNS. So over to you, sir.
Thank you. I think 3 to 4 weeks back, we discussed the first part of central nervous system infections, in which we covered the important bacterial meningitis and the suppurative infections of the CNS and the some shunt infections, the basics. Today, we will continue with the important community-acquired CNS infections here. Today's class, we will discuss the viral encephalitis as a whole together topic rather than the individual viral discussions, and some important aspects regarding the chronic meningitis, which is very important both for the entrance and the practice purposes. So the acute viral encephalitis is a deadly thing which we usually don't want to see in our routine practice, because many of the times it is missed in the diagnosis. And after missing, the treatment is also very improper, and the recurrence is very common. And sometimes the management is very poor in the viral encephalitis section, because the only we know that herpes virus has got a significant antiviral therapy, whereas other viruses we need to manage just symptomatically. We don't have any separate management for all the viruses. So altogether, the viral encephalitis is uncommon, but it is potentially devastating. Uncommon means it's not so rare, but it's definitely less common than the bacterial meningitis. But as a group, these infections range from the benign, they can be benign self-limited forms of infection. Sometimes patient may not present to you at all, whereas sometimes it becomes very fatal. And sometimes it may progress into become a chronic, recurrent, or a persistent disease of the central nervous system. So again, before going into the discussion per se, as we discussed in the last class, it is very important to understand the difference in the definitions of what is encephalitis and what is meningitis. We know that encephalitis means it is literally the inflammation of the brain parenchyma, whereas meningitis is associated with the inflammation of the leptomeninges, that is the subarachnoid space. So what defines an encephalitis? So why this is important? Because we know that the entire etiogenesis of the meningitis and the encephalitis is different. When you write a diagnosis of meningitis in the case paper, then the first thing which should come in the picture is the bacteria as an etiological diagnosis. Whereas if your diagnosis is an encephalitis, then it is the viral etiology that is important. So and even in the points of entrance also, they may trick you the question by asking the questions like this. So here, if you see this question, there's a 60-year-old male patient, 60-year-old patient was admitted in emergency with seizures, aphasia, and altered sensorium. He has a history of fever and headache for the preceding 3 days, and the CSF examination is unremarkable. What is the most likely diagnosis? And the options given are the aseptic meningitis, the bacterial meningitis, the viral encephalitis, and the tubercular meningitis. So what do you think is the diagnosis here? See, what defines the encephalitis is the involvement of the brain parenchyma. So there has to be an abnormal cerebral functions. That is very, very important. Whereas meningitis, the cerebral functions are not altered, but it is just an inflammation of the leptomeninges in the subarachnoid space. So what constitutes this abnormal cerebral function? See, when the patient presents to you with the altered sensorium can be of any level, like patient may be just confused, patient may be just stuporous, patient may be into the frank coma, but you need to know what is this definition. Just a mere altered sensorium is not a thing which differentiates from the encephalitis and the meningitis. So what are the abnormal cerebral functions which we need to know? We know that first is obviously the altered mental status of any kind. If mental status is altered, it takes more towards the encephalitis, especially if the patient is in coma. Whereas the meningitis patient, due to the headache and due to the superficial edema, so they may be a little bit stuporous, a little bit confused. Whereas the frank coma is very common in case of encephalitis. And any focal neurological deficits, like if the patient has any sensory deficits, patient has any motor deficits, patient has any speech deficits. So all these kinds of deficits usually goes in favor of encephalitis. And patient with personality changes or behavioral changes. Patient is behaving abnormally, it usually takes in favor of encephalitis rather than the meningitis. And obviously the speech abnormalities takes towards the diagnosis in the form of encephalitis. Although the pure differentiation in case of the routine practice may be difficult, but we need to know what is actually encephalitis and meningitis, and many of the times they may coexist together, the condition as a meningoencephalitis. So if you see this question, the patient has the seizures. Seizures can occur in both meningitis and encephalitis. Altered sensorium can also occur in both meningitis and encephalitis. So if you know this seizures is not specific for encephalitis, please remember this. Whereas this aphasia, it is a focal neurological deficit. It is the deficit in the speech. This is a very typical of encephalitis. So aseptic meningitis, if you know what is aseptic meningitis, it is just a meningismus. That means there is a meningitis. Clinically, patient present with features of meningitis, that is headache, neck stiffness, with or without fever. And if you do the CSF analysis, there may be meningitis. That means there may be some amount of pleocytosis. There may be some amount of increased protein, whereas there is no growth. The PCRs of the viral is negative, and the gram stain is negative, the AFB stain is negative, the culture is negative, nothing is grown. Then it is called as aseptic meningitis. Here the patient, it's a benign condition. Patient usually does not have any altered sensorium, aphasia, the seizures are very rare. And bacterial meningitis per se, the seizures can occur, altered sensorium can occur. Aphasia in some bacterial meningitis do occur, but it is less common. But the clue here is the CSF examination that is unremarkable. This is very rare in case of the bacterial meningitis. The CSF examination invariably will be abnormal in case of bacterial meningitis. So right answer here is the viral encephalitis. So it is important to know the difference between the definition of what is meningitis and what is encephalitis per se. So if you know the etiology of this viral encephalitis, actually more than 100 viruses can infect the human CNS. But among this, only much smaller cause of the viruses causes a clinically significant and clinically important viral encephalitis. And although this group of infections or the etiological diagnosis causing viral encephalitis is increasing, because nowadays the AIDS epidemic is going on, the newer and newer viral etiologies are going to get discovered, just like COVID. Then therapeutic use of the immunosuppression, a lot of organ transplant patients are surviving with increased survival rate. And again, immune defects that occur in oncology patient can be completely unpredictable. So the more and more new viral pathogens are getting discovered. And we know that many immunocompromised hosts now require a discrimination between an ever-expanding list of the infectious and non-infectious cause of an acute encephalitis-like picture. That is what we called as an acute encephalopathy. If we use the terminology called an acute encephalopathy, it can be anything. It can be either infective, it can be due to non-infection conditions, like it can be due to metabolic, it can be septic, it can be hepatic, it can be uremic, it can be any encephalopathy. So it is very important to differentiate between the infectious causes of this encephalitis-like picture and non-infectious causes of this encephalopathy. So this is the viral etiologies of the viral encephalitis. If you know, the most important classes are the Herpesviridae. Among this, the herpes simplex virus is the most common cause of the acute viral encephalitis, especially the herpes simplex type 1. is the most common cause of the sporadic as well as epidemic viral encephalitis. Whereas other herpes viridae are less common compared to the herpes virus, like other herpes virus like varicella zoster, the cytomegalo, the Epstein-Barr, HHV 6, 7, and 8. They are very common in the immunocompromised host rather than the immunocompetent host. And other classification, very important, is the alpha viruses. These the equine encephalitis virus in both Eastern and Western America, and the Venezuelan equine encephalitis virus, and the flaviviridae, where these are the arthropod borne, are very, very important. These in the category of Japanese encephalitis, the St. Louis encephalitis, the West Nile virus, the tick-borne encephalitis virus, and the dengue virus. Among this, the West Nile, the Japanese, and the dengue are the encephalitis transmitted through the mosquitoes. This is also very, very important. Whereas if you see the other rare viruses, the paramyxoviruses like the measles, mumps, rubella, the Nipah, Hendra are less common, although we know that recently there is a Nipah virus outbreak in the worldwide, in also India. The viruses like JC virus is common in causing the progressive multifocal leukoencephalopathy in the immunocompromised patients, especially in the HIV patients, and other patients like other viruses like the Coxsackie virus, the polio virus, the enterovirus group. They are mainly the causative organisms of aseptic meningitis. So if somebody asks you what is the most common cause of most common viral etiology of aseptic meningitis, it is the enterovirus. Most common cause of the encephalitis is the herpes simplex virus type 1. And nowadays we have got some new viruses coming into the picture, that is, we know Zika virus in causing the notorious microcephaly in a patient of infected during the pregnancy. Then Nipah virus, which we don't have any treatment, which is basically transmitted through the pigs and the bats. Recently we had an outbreak in Kerala. Fortunately, it did not spread much. And the Toscana virus, although not in India, had an outbreak in some different countries. So if you know, there's a lot of varieties of the viruses can cause the viral encephalitis. The clinically important one is the herpes simplex 1, because this has got a separate treatment. Whereas other viral encephalitis, the management is purely symptomatic. We don't have any specific therapy pertaining to those infections. So what are the clinical manifestations? If you see, it can range from the mild to severe, that is extreme manifestations. The patients of the acute viral encephalitis, they can develop a very rapid symptoms, and they may be progressive, evolve within days to weeks. If you see the herpes virus encephalitis picture, the patients are completely normal. So they suddenly present with a high-grade fever associated with the loss of the sensorium with the behavioral abnormalities, along with the signs of rise in intracranial tension. So if you see the manifestation, it is usually the combination of the fever, symptoms of meningitis plus or minus, plus the symptoms indicative of the brain damage. So it is either seizures or the behavioral changes or the focal neurological deficits and the altered sensorium, which may progress into coma. So any patient who presents with fever and the encephalopathy-like picture, you need to suspect the viral encephalitis as the possible etiology. So what can be the etiological clue which can have the etiological diagnosis? So if a patient has parotitis along with the encephalitis, then the etiology can be mumps, which is very easy to predict. So the flaccid paralysis, a polio-like presentation that evolve into the encephalitis, can be the West Nile virus, where it is along with the encephalitis, it can also cause the peripheral neuropathy, the radiculopathy, and the anterior horn cell involvement. The tremors of the eyelids, tongues, lips, and extremities are common in case of the Japanese encephalitis and also West Nile encephalitis. Then we know that the hydrophobia, aerophobia, the pharyngeal and laryngeal spasm, along with the hyperactivity or hypermania, can be a feature of rabies. With a history of dog bite, Then a grouped vesicle in a dermatomal pattern is very common with the varicella zoster virus. See, there are some etiological clues, although it is not possible to identify the etiological clue with just a mere clinical presentation in all the viral etiologies. In some, it is common, like herpes patient may have the skin lesions, the herpetic lesions, especially the around the mouth and the genital area. They may coexist or they may not coexist. If it is a primary herpes infection, they may have. If it is a reactivation, they may have different presentation, as you know. Then we know that the etiological clue can be identified based on the viral neurotropism. That means if you see the brain imaging, this particular virus has got a tropism towards the particular area in the CNS, like the herpes simplex virus. The most common area which is affected is the temporal lobes and the inferior frontal lobes. And the Japanese encephalitis virus involves the deep brain structures like thalamus and basal ganglia, which is also similar in case of the West Nile virus. And the varicella zoster virus is important in causing the cerebellum. This is especially important in a patient who presenting with an acute ataxia after improving from the herpes zoster. It is very common in practice. Then this cytomegalovirus, although it does not have any particular predominance, the periventricular area involvement is also very, very common, along with some necrosis in a feature of HIV. Then rabies involves the limbic system. Then the Epstein-Barr virus can cause the cerebellar angiopathy. It has got a particular predilection towards the cerebral blood vessels. So it can cause the cerebral angiopathy by involving in the endothelial cells. So these can be the straightforward entrance questions, like fact-based questions, which you should know that which of the herpes virus have a predilection to involve the cerebral blood vessels or the endothelial cells, or which can cause the angiopathy. So then the answers can be the Epstein-Barr virus. As the questions might appear like this also, which encephalitis might need the MR angiography of the CNS? Then it is the Epstein-Barr virus. And sometimes EEG can occasionally aid in the diagnosis if there is a focal predominance, like if an acute focal encephalitis is suspecting. Sometimes these EEG findings do appear even before the imaging abnormalities appear. Like if you see the herpes simplex, the imaging abnormality which is lateralizing to the temporal lobes can appear even before the MRI involvement of the temporal lobes. So these any periodic and lateralized epileptiform discharges are there. If the epileptiform discharges are lateralizing to one particular lobe, especially this is very important in case of temporal lobe involvement, can identify the herpes simplex encephalitis. Why this is important? Because the early treatment is very, very important in case of prevention of the morbidity and mortality in case of herpes virus infection. And one important thing which everybody of us should remember is if there is an EEG evidence of seizures during the course of infection, you need to start the patient on anti-epileptic dose, anti-epileptic drug, even without the clinically important seizure. If the patient may not have thrown seizure in front of you in the hospital, but if you have done the EEG, if he is having an epileptiform discharges during the course of infection, you need to start the patient on anti-epileptic drug. So the brain imaging, although CT or MRI are important in diagnosing the infection, it is the MRI which is very, very important. It is with or without contrast, with or without diffusion weighted images. So if you see the first image here, see the hyper intensity which is seen in the inferior temporal lobes, although it is bilateral but is asymmetric. It is much more common in the right side compared to the left side. So this is very common with the herpes simplex encephalitis. So that's why these patients do present with the features which are pertaining to the temporal lobe involvement and the limbic area and the frontal eye field also. Like the patient may have a features of the hypermania or hypomania. Patient can have a feature suggestive of the very famous Clover-Bucy syndrome. Patient can have also the behavior abnormalities. So the Kluver-Bucy syndrome is nothing but a hyperorality, hypersexuality, and the mania. This is what the Kluver-Bucy syndrome is. So these behavioral abnormalities need to be suspected in a patient. Like patient may not have any fever sometimes, especially the immunocompromised patients. Sometimes the patients are being suspected and taken to the alternative medicine based on the behavioral abnormalities. Later on, they found out to be having herpes encephalitis with the treatment being delayed, guarding their prognosis. So if you see the second image here, see the involvement of the basal ganglia. This is a part of basal ganglia, the deep brain structures. Although the thalamus sparing is there, so this is very, very common in case of the West Nile virus encephalitis. The deep brain structures are very commonly involved in this particular thing. West Nile virus encephalitis. Other than cortical lesions, the deep brain structures like thalamus, the basal ganglia, ventral capsule, the subcortical white matter, these are the areas which show hyperintensity in case of West Nile virus. Although it is not a hard and fast rule, these are the most commonly observed radiological abnormalities. So if you see this third image, see the thalamic hyperintensity. This is a very pathognomonic sign of the Japanese encephalitis. Bilateral thalamic hyperintensity with or without hemorrhage, thalamic hemorrhage. So it is very, very important. So this is an internal capsule, this is a posterior limb, this is an anterior limb. So sorry, this is an anterior limb, this is a posterior limb. So this is a thalamus. So this thalamic hyperintensity is very common in case of the Japanese encephalitis. Although in India nowadays the Japanese encephalitis incidence has reduced due to the routine immunization which has been included in the Japanese what you call the infant or the children immunization schedule. But still in the states like the UP, Delhi, the Bihar, the Japanese encephalitis is still being very rampant due to the mosquito-borne infection, especially which is predominant in the early summer, late summer and the early spring. So when I was in Delhi doing my MD, the Japanese encephalitis is very, very common even in adults. Although the risk group here is the 5 to 15, many of the population do belong to the pediatric population. Even the adult population used to come with the Japanese encephalitis, the PCR being positive. So the Japanese encephalitis still need to be controlled in India. Although in South Indian states, it is very rare. I have not seen a single Japanese encephalitis after moving back to Karnataka. But it is possible to see anywhere in India. So the CSF analysis, if you see, it is mandatory. You cannot forfeit the doing CSF analysis in case of suspected viral encephalitis. If you see the characteristic picture here, the lymphocytic pleocytosis and the mildly elevated CSF protein with a normal CSF glucose is a triad of viral encephalitis. So any patient who presents with fever and altered sensorium with a CSF picture suggestive of viral encephalitis needs to be started on acyclovir. Please remember this. You need not wait for the etiological diagnosis. You need not wait for the herpes simplex PCR or the other PCR to be positive. You can just straight away start the patient on acyclovir if the patient's CSF profile is suggestive of the viral encephalitis. So generally, all the viral encephalitis have a mononuclear cell pleocytosis of not more than 1,000 cells. The extreme pleocytosis is very, very rare. Whereas there are some encephalitis where they can have a polymorphonuclear cell pleocytosis, especially in an early stage of the herpes simplex encephalitis and the. Although I have not seen viral encephalitis herpes presenting as a neutrophilic predominance, but West Nile virus encephalitis presenting as a neutrophilic predominant pleocytosis is very, very common. This is also an entrance question, have been already asked. But if you do a CSF early in case of herpes simplex, so it can still have a neutrophilic predominance. And total protein content may be normal in the first week of the disease. Like if you have done the first week CSF, the protein can be normal. You cannot just rule out the possibility of viral encephalitis. You need to have a repeat CSF after the end of first week. And hypoglycemia, that means low glucose, is very uncommon in case of viral encephalitis, whereas there is one particular virus that is lymphocytic choriomeningitic virus can have the low glucose in case of the viral encephalitis. These are the exceptions, and these exceptions are the questions which appear in the entrance world. And viral cultures are very, very invariably negative because of the less yield. So the etiological diagnosis is mainly through the serological diagnosis in the CSF. Sometimes the serum serological diagnosis are also being carried out. So any patient or all patients with fever and focal neurological deficits and the CSF pleocytosis should be treated for a presumptive herpes simplex encephalitis until an alternative diagnosis is confirmed. The patient may have a demyelinating condition, patient may have a metabolic encephalopathy. It doesn't matter if your patient has fever, focal neurological deficit, and a CSF pleocytosis. Start the patient on a presumptive diagnosis of HSC and acyclovir till you establish a proper diagnosis. And the pathogen-specific assays. Nowadays, the serological assays are available for almost all the viruses. We have got the multiplex PCR, as I told in the last class also. We usually send this multiplex PCR of the CSF analysis. The reports are usually available within 4 to 6 hours. So many of these tests can be applied for the serum and CSF, but it is better to send CSF. And the antibody-based tests are difficult to perform and interpret in the early disease. And PCR-based tests are the now routinely recommended tests. So initially, we used to get the HSV, IgM, or IgG from the CSF, but it has been obsolete now. Go for the PCR-based techniques. So, for example, in the case of the herpes simplex encephalitis, the PCR got a very high sensitivity and specificity compared to the gold standard brain biopsy. The brain biopsy is an invasive procedure. So it is better to go for the PCR-based amplification techniques to diagnose the condition. So how will you manage this acute viral encephalitis? There is a specific antiviral therapy which has been available only for herpes simplex and the cytomegaloviruses. Whereas all other viruses, it is just a general supportive care, like patient need to have a seizure control with a good choice of the drugs and reduction of the ICT. This can be done with a 3-tier system. The level 1, we know that is usually head and elevation and the mannitol and the hypertonic saline. In the second, patient can have the increased hypertonic saline. The patient can have a pentobarbital coma, and patient can be taken into the hypothermia. All these are there, which you need to be followed to reduce the ICT. Then the stress ulcer prevention is very, very important, and you need to prevent the occurrence of the systemic complications, and you need to manage the comorbidities altogether. Like if the patient is having a diabetes, you need to have a strict glycemic control in these patients. So what are the treatment regimens for the acute viral encephalitis caused by the herpes viridae? For the herpes simplex viruses encephalitis, we have got some drugs available. It is acyclovir, the historical drug. Then we have got a valacyclovir. Then you have got ganciclovir. Then you have got the famciclovir. So these are the drugs available. Although it is acyclovir is a drug of choice, what is important in case of acyclovir is the dose, the duration, and the preparation of the drug while administering is the most important thing. Please remember the dose of the acyclovir is the 10 mg per kg every 8th hourly. There is no scope for oral acyclovir. This is a very, very important thing. Even after improvement, for whole duration, that is 14 to 21 days. Initially, it was followed for the 10 days, but nowadays, all the standard textbooks, all the guidelines mentions the duration of the treatment is 14 to 21 days. This can be the entrance question because the recurrence, if it is not treated properly, is very, very high. I have seen many of the patients with improper treatment coming back with an episode of the viral encephalitis if it is not treated properly. So the dose is the 10 mg per kg, IV 8th hourly. The preparation should be in such a way that the concentration should be less than 7 mg per ml of the saline. This is particularly mentioned in the Harrison, and this is clinically important also because it is a nephrotoxic drug. and it is very important in causing the crystalluria. This crystalluria can cause the post-renal AKI and complicated management. So the acyclovir needs to be given at a dose of 10 mg per kg with a preparation of 7 mg per ml. What does it mean? For example, if the patient is weighing 70 kg, then the dose is 700 mg TID. So how will you prepare this 700 mg to be given? So if you give the advice of 700 mg of acyclovir plus 100 ml NS, so every 1 ml contains 7 mg. So this should not be the picture. It should be less than 7 mg per ml. So this 700 mg to be diluted in at least 200 ml, so that 1 ml contains 3.5 mg. So this is the way you need to prepare the acyclovir to prevent the acute kidney injury to occur in your patient. So this is a very, very important. Many of the people in the practice forget this issue with the acyclovir. So when you give acyclovir, the duration is very, very important. The dose is very, very important, and the preparation is very, very important. The dose has to be given only intravenous for all the 14 to 20 duration. There is no scope for oral acyclovir. The dose is 10 mg per kg, which is given 3 times daily, that is 8th hourly, and preparation in such a way that each ml of your saline contains less than 7 mg of the acyclovir. If the patient is having acyclovir resistance, you cannot use the other cyclovirs also, like you cannot use the acyclovir, you cannot use the pencyclovir, you cannot use the ganciclovir because of the cross resistance. So the drug of choice for the acyclovir resistant herpes simplex is the foscarnet. This can be the entrance question. Drug of choice for the acyclovir resistant herpes virus, and the dose here is the 6 times more than the acyclovir, that is 60 mg per kg IV TID for 14 to 21 days. This also has got a similar side effect profile. So this is a very, very important treatment as far as the acyclovir is concerned, which everybody of us should remember. Then again, CMV, which you might have studied, the drug of choice for the CMV is the ganciclovir plus foscarnet. It is always the combination therapy is the drug of choice, and the duration is 21 days. We know that the ganciclovir is a notorious drug in causing bone suppression, rash, and also nephrotoxicity. So if the patient is not tolerating ganciclovir, then the next drug is the cidofovir with the probenecid. This is very, very important. The probenecid should be given 3 hours before giving cidofovir, and 1 hour before giving cidofovir, and after 8 hours after giving the cidofovir. This is also very, very important. If you go through the treatment chart of the CMV, you will know it is, although it is very rare in clinical practice to see the CMV by the primary care physicians, but if you are managing in the tertiary care hospital, you do encounter the CMV infections, especially in a post-organ transplant patient and in the recent COVID era. I think 2-3 patients I have seen in the COVID era where there is a reactivation of CME presenting as some GI ulcers, GI bleed, etc., where we need to give the ganciclovir, or some in one patient we had given cidofovir also 2 years back. So this is very, very important. The CMV, if you are diagnosed, the CMV also needs some maintenance therapy with the ganciclovir and foscarnet, or you can use the oral ganciclovir for the maintenance therapy of the CMV. So the only oral therapy in the Herpesviridae encephalitis is the ganciclovir. That is only for CMV, that too only in a maintenance therapy, not in the inductive therapy. This is very, very important. You should know as far as the management of acute viral encephalitis is concerned. So then some clinically important encephalitis related to measles, it is very, very important. Although measles per se is very rare in causing the primary encephalitis, but there are unique features of this measles which everybody should remember. Although due to the routine vaccination, the measles encephalitis has definitely reduced. The measles, we know that it can get complicated by having an immunosuppression. Patient can get pneumonia, patient can get encephalitis. The encephalitis is a deadly condition, sometimes progressing into death. The pneumonia caused by the measles, if you can remember, it is called as H pneumonia. It's H-E-C-H-T. H is a scientist, H pneumonia, where it can have the giant cells in the pathology. And the encephalitis is also called as H encephalitis. So there are three varieties of this encephalitis related to measles are existing. One is the post-infectious encephalomyelitis. Then there is an inclusion body encephalitis that is also called as MIBE, that is measles-induced inclusion body encephalitis. Then a very famous, that is subacute sclerosing panencephalitis. This is a Wikipedia of an entrance question. I think everything related to the Ssp has been asked in all the AIMS or PGI based questions already. So these three varieties of the encephalitis caused by the measles should be remembered. They give a clinical scenario related to the measles, then they will ask you to diagnose what is the problem in the patient. So if you see this post-infectious encephalomyelitis, this is not a viral infection, whereas this is a reaction to the virus. So this is a demyelinating condition. Whereas this inclusion body encephalitis and SSPE are actually the viral invasion of the CNS. And in what patients these usually appear? This is also very, very important. The post-infectious encephalomyelitis and the subacute sclerosing panencephalitis usually appear in the normal host, whereas this measles-induced inclusion body encephalitis occurs only in case of the immunocompromised host. It is not seen in a normal host. This is an entrance question again, very, very important. And what is the incidence of these infections? The most common is the measles-induced inclusion body encephalitis. If the patient is immunocompromised, among the 10 patients who are immunocompromised, the one is definitely going to get the MIB. Whereas if you see the encephalomyelitis, which is a demyelinating condition, which is seen in only 1 in 1,000 population. And the SSPE is very rare. It is 1 in 10,000, maybe much lesser. And the post-infectious encephalomyelitis is a monophasic condition. This is a one-time hit. After recovering from the measles infection, patient usually have an episode of a demyelination in the central nervous system. So this is a monophasic infection. If you treat that particular entity, then it is going to recover. Whereas the inclusion body myositis and the SSPE are the progressive conditions. And when they do appear, this is also very, very important. This post-infectious encephalomyelitis usually appears after weeks after recovering from the measles, whereas the inclusion body encephalitis appear after months after recovering from the measles, whereas this SSPE appears after years after recovering the measles infection. And very, very important is the primary episode of measles. If occurs in less than 2 years age group, then only the SSPE is seen. Whereas this post-infectious encephalomyelitis is seen only in patients who have a primary measles infection only after the age of 2 years. This is also very, very important. And all these points are the potential MCQs which everybody of us should remember. And as far as the SSPE is concerned, everything is important, which is a very rare condition in 1 in 1,000 population. Sorry, 1 in 10,000 population. And it is seen in a normal host. It is not seen in an immunocompromised host. It is a progressive condition. It is seen after years. Like Harrison mentioned, the risk age group is the 5 to 15 years. Like if the patient has a primary measles infection less than 2 years of age, after they get 5 to 15 years of age, they start to manifest as a feature of SSPE. So what are the clinical features of SSPE, which everybody of us should remember? We know that there are stages. There are complicated stages in the internet or in the textbooks, but everybody of us should remember in an easier way. The first stage is the subtle changes. The subtle behavioral changes are seen in a child. The second stage is a stage with myoclonus. The patient start presenting with the myoclonus jerks. The third stage is a patient who presents with involuntary movement like choreoarthrotoid movements. Then in fourth stage, the patient becomes progressively involved in the whole central nervous system, may progress into frank coma or the vegetative state. So this is a very, very important. In the PGI, they have asked the question regarding the staging also. So you should know if there is a myoclonus, then it is stage 2. If it is coma, then it's stage 4. In between those two, it is stage 3. Then we have got the some criteria also. I think it is some Dynex criteria. Also. I don't remember exactly what is the name. But what is important is the diagnosis of this SSPE. I think 10 years back, we had a brain biopsy as a diagnosis of choice, whereas nowadays it is diagnosed on the clinically compatible patient with the ECG in the background. So what is the typical ECG we usually get in case of the SSPE is this particular thing. So there is a high amplitude spike wave complex. This is a high amplitude spike wave complex which usually appear for 1 to 3 seconds in a patient. Then there is a period of silence for 4 to 16 seconds. Then again, there appear a spike wave pattern for a period of 1 to 3 seconds. Then again, a period of silence for 4 to 16 seconds. So there is a regular rhythm. This is like what you see in a heart rate, like it is regularly, irregular. So this is a regular complex of a spike wave pattern. But the spike wave appear for 1 to 3 seconds, and some in between 4 to 16 seconds there is a slow wave. So this is a particular complex that is what is called as Radermacher complex on a diagnosis which is typical of the SSPE. This can be the entrance question as related to the SSPE also. And what is important here is the treatment. Treatment is just supportive. We don't have any definitive management, but one very unique feature of this SSPE is the drug of choice for the myoclonus is carbamazepine. So drug of choice for the myoclonus in case of SSP is carbamazepine. Why this is unique? Because carbamazepine is actually contraindicated in all other myoclonuses. It tends to worsen this typical seizure, that is myoclonus. Whereas SSP is the only condition where we use carbamazepine as a treatment for myoclonus. This is also an entrance question. And again, the treatment is just supportive, although Harrison mentions the combination of the isoprenaline plus the interferon alpha, that is intrathecal interferon alpha, has shown some benefit, and recently the ribavirin therapy has also shown some benefit, but in the clinical practice, it is just a progressive condition. The patient is either going to die in 90 to 95% of the case, or they may survive with a very high morbidity as a bedridden in a vegetative state. So if you say, if you have a habit of watching the Dr. House MD series, in season 1 and episode 2 is a patient of the SSP. So here they have shown that the person who presents with some behavioral abnormalities responding to the intrathecal interferon alpha, whereas in routine practice it is very rare to see. So again, this is a graphical representation of this. We need to know the time duration. The first thing which appears after the measles infection is the acute post-infectious encephalomyelitis. Then in months, it is the infusion body encephalitis only in immunocompromised. If the patient is not immunocompromised, then this is going to overcome. Whereas the SSPE occurs after years, and it is a progressive condition with a very high mortality as near as 100%. So this is a very, very important. So it is very important to study the measles-related encephalitis, especially the SSP, a must revise topic before going into the entrance questions. And the recent advances as far as viral encephalitis is concerned is not much in the management aspect, although the newer varieties of diagnostic modalities are being coming. but the treatment aspect, it is very less. Whereas there is a novel target for the viral encephalitis therapies, that is CXCL1, that is a co-stimulator in the inflammation in the neutrophils. So targeting this has shown some benefits. So I think this is a study which is published in the Johns Hopkins Medicine Journal in 2017. Though it has been tried in the Japanese encephalitis also, but still none of the drugs related to this class have been approved in the management. In the future, we might get approved. And some important things about the chronic and recurrent meningitis. So arbitrarily, the duration which defines the chronic meningitis is the 4 weeks, that is 1 month. So any patient who have a persistent symptoms just of meningitis for more than 1 month, then he is labeled as the chronic meningitis, because the etiology is completely different here. That is why this particular is important. And it is being diagnosed as a persistent inflammatory response in CSF with the pleocytosis. So you have done a CSF in the day first, patient is not improved in the months, you have done the repeat CSF, then again it is showing the pleocytosis, then it is labeled as chronic meningitis. Very, very important thing. So how will you predict, or how will you suspect this? The patient usually presents with a variety of manifestations. Patient can have a feature suggestive of the central meningitis, like the leptomeninges which are covering the cerebrum may be inflamed, or patient can have a spinal meningitis, where may patient present as the radiculopathies or sensory neuropathy like picture, also very, very common. Or patient can have the abnormalities in the CSF drainage due to the chronic inflammation in the leptomeninges. CSF drainage has been abnormal, which can cause the hydrocephalus in the patient. So if you are seeing any patient with a persistent headache, the hydrocephalus, cranial neuropathies, and the radiculopathies, and some cognitive or personality changes, either in alone or combination. Like one of the presentation is a very common in the day-to-day practice, the persistent headache. So you need to have a high suspicion for the chronic meningitis in the practice. So the neurological manifestation of this chronic meningitis are unique to the anatomic location of inflammation and its consequences. So the spinal meningitis presents as radiculopathies, where you may misdiagnose a patient as diabetic neuropathy, where in fact a patient can have a chronic spinal tubercular meningitis, which need to be treated properly. So the patients can have a chronic headache as a symptom here, chronic backache. See this presentation, a very common presentation, where you may elicit a Brzezinski sign, Kernig sign. So it needs to be very, very important. The clinical examination, how you examine the patient and how you suspect the disease is very, very important here. And some recent change in the personality is also very, very important. Then some weaknesses like facial weakness and double vision. I've got a case here which was seen in my own practice 2 months back. Then visual loss, the patient can have a presentation with papilledema. Patient can just present with the hearing loss, like eighth palsy can be there. Patient can present with a single limb weakness secondary to myelopathy or radiculopathy. Patient can present with a sphincter dysfunction. Patient can present with clumsiness or ataxia. So you need to have a very high suspicion for this chronic meningitis. So this particular patient 2 months back is a image from my own patient only. This patient who had a feature of diplopia, was uncontrolled diabetic, who went to a quack with a diplopia, who gave him some eye drops. The diplopia didn't reduce. Then the patient was sent to the ophthalmologist. The ophthalmologist saw the patient and referred to the neurologist, but due to unavailability of neurologist, the patient could not consult a neurologist. So this occurred with a 1 month duration. Then the patient came back to the same quack. So the patient got his CT head done. Sorry, the quack. The CT head was normal. Then the patient was referred to me with the diplopia. The patient had the third nerve palsy. And the patient was not ready for the MRI. The patient instead got ready for the CT contrast, as it was available in a small place. So this is the image of CT contrast where it is showing a typical basal meningitis. So this is the basal meningeal enhancement. So the patient was ultimately diagnosed to have a tubercular meningitis in this particular scenario. So this is a way of presentation which can be completely deviate from the normal presentation. So that's why we need to have a huge suspicion for the management. So one clinical clue which everybody should remember in their practice is it is never wrong to over-investigate the patient. But what I have understood in my recent practices is never under-investigate the patient. You can overestimate, you can over-investigate the patient. Even if patient coming with a headache, it is no wrong in getting the CT done. But if you're not got the CT done, and if the patient dies with some subarachnoid hemorrhage, then it becomes a very huge negligence from the doctor's side. So never under-investigate the patient. It is always better to over-investigate, especially in the present era of so much harassment on the doctors. Then what are the causes of this chronic meningitis? So if you see the acute bacterial meningitis, it is only the infectious cause, whereas the chronic meningitis cause, the infections are only part of the etiology. The lot of chronic meningitis can be caused by the malignancies. So it can be from the primary CNS malignancies, or it can be from the metastasis. Then there are some autoimmune inflammatory disorders. The autoimmune encephalitis is a separate entity or a separate discussion in which there is a terminology of paraneoplastic encephalitis also. And the chemical meningitis. So this chemical meningitis can be due to some chemicals or some drugs. Then parameningeal meningitis, like patient may have a sinusitis. Although this infection may not have spread to the leptomeninges, but due to some spillover, patient can have a parameningeal meningitis. Same can occur in otitis media, mastoiditis, sinusitis, etc. So if you see the meningeal infections, a lot of varieties are seen here. The bacterial, the viral, fungal, and parasitic infections are common. And bacterial, the partially treated acute bacterial meningitis, especially if the history is available, patient was not treated properly, the dose of the antibiotic was not right, the duration was not right, the choice of antibiotic was not right, then you need to suspect a partially treated acute bacterial meningitis can present as a chronic meningitis. Tuberculosis, everybody of us should know. Then Lyme disease, as I have discussed you in the case reports, the borreliosis, especially the Ban-Wast syndrome. Again, this question was asked in 2 days back in NEET SS. Ban-Wast syndrome. The Lyme disease can present with the chronic meningitis. The syphilis is the known cause of chronic meningitis. Then some rare infections like actinomycosis and nocardiosis. What important you should remember is these actinomycosis and nocardiosis meningitis can have a neutrophilic pleocytosis. Whereas if the chronic infection, we usually expect the mononuclear infiltrates. The actinomycosis and nocardiosis, especially in the background, if in case of actinomycosis, if you have some sinuses draining in the head and neck area, nocardiosis, if the patient is immunosuppressed, if the patient is having pneumonia, especially the necrotizing pneumonia, you need to suspect these infections, and they may have a neutrophilic predominance in the pleocytosis. Brucellosis, again, you need to suspect when the patient is working in case of the animal husbandry, where the patient have a habit of drinking unpasteurized milk, etc. The Whipple's disease, although very rare, and leptospirosis per se, very rare. Then viral, it is the non-herpetic viruses which are usually common with the chronic meningitis, especially the mumps, the lymphocytic choriomeningitis, the ecoviruses, the HIV as a part of its acute antiretroviral syndrome can cause this, and HHV, especially the HHV 6, 7, 8, can cause this chronic meningitis. And fungal, the cryptococcus, especially in the immunocompromised patients. Then the coccidioidomycosis in the unique endemic settings. And the candidiasis, if the patient have a immunosuppression, if the patient have a use of recent antibiotic use and antifungal use, need to be suspected with this. Then histoplasmosis, the blastomycosis, aspergillosis, these with the immunosuppressed condition, you need to have a huge suspicion. And then some Parasitic infections like Toxoplasma encephalitis is also very common. The trypanosomiasis caused by the trypanosome organisms are also very common. The acanthamoeba can cause the granulomatous encephalitis, along with the organism called Balamuthia. You might have studied in the microbiology. Then cysticercosis can have a space occupying lesion along with the spillover encephalitis and meningitis. And some rare parasitics like the Gatostoma spinigerum, Angiostrongylis, all these are very common, not so common in case of the chronic meningitis. And malignancy, as I shown, it can told you it is either primary or metastatic. And autoimmune can be either the as a part of mixed autoimmune diseases or as a part of paraparetic syndrome. Then, like the CNS sarcoidosis can have the chronic meningitis. How do you suspect this? If the patient has the cranial palsy, especially the seventh, in the background of element palsy, or if the bilateral facial palsy. As I told you in the last class also, the bilateral facial palsy is very less common. If it is seen, you need to suspect either sarcoidosis or Lyme disease. And if the patient is having the hypothalamic dysfunction presenting as a diabetes insipidus, and especially the abnormal chest X-ray and peripheral neuropathy, we know this is a multi-organ disease, so you need to suspect this CNS sarcoidosis. And there is a syndrome called VKH syndrome, that is Oaked-Koyanagi-Harada syndrome, where there is involvement of the eyes with the brain. So patient can have a uveitis, the cataract, the glaucomas, the retinal detachment, all these can be there. Then this isolated granulomatous angiitis of the nervous system is very common in case of the virus, zoster virus also. So this can present as a subacute dementia, the multiple cerebral infarctions, especially the background of history of recent zoster ophthalmicus, and SLE with the feature which are suggestive of SLE, like the cutaneous manifestations, the alopecia, the arthritis, the nephritis. You need to suspect this. Then Behcet syndrome with the genital and oral ulcers which are recurrent. You need to suspect this. And IgG4 related diseases can present as a hypertrophic meningitis. Then chemical meningitis, especially if the patient has a history of some injection into the subarachnoid space, and if the patient has a surgery with a recent resection of some tumors where they may have irrigated the surrounding area, which might have caused the chemical meningitis. The pituitary apoplexy, many of the times you may have seen the clinical manifestation of pituitary apoplexy with the meningismus also. So this is because of some spillover chemicals coming into the meninges and causing chemical meningitis. And some drugs, especially the drugs causing meningitis, can be the entrance question. The most common are the NSAIDs and the sulfur-related drugs. Very important. So these are clinical clues which you should be considered in case of chronic meningitis, because it is very impossible to go for all the investigation which are possible. So all the clues you need to gather before going into the specific investigation in the evaluation of this chronic meningitis. And again, how will you manage the patients with the unknown cause? Even after extensive evaluation, like what are the evaluation which we usually do is the repeat Csf analysis, the brain imaging. There may be a need for the meningeal biopsy, or sometimes the brain biopsy, and the related serological tests. So even after extensive evaluation, you cannot achieve a diagnosis, then you need to treat the patient as an empirical therapy. You can start the patient on empirical antitubercular therapy to know the response. Although in tubercular meningitis, we try with the steroids. Here it is given without steroid. Whereas you can, apart from antitubercular therapy, if you're damn sure that it is not a tubercular meningitis, you can give a trial of glucocorticoids due to the possibility of the autoimmune meningitis, and antifungal therapy, and some antiviral or antibacterial therapy to consider the rare infections can be considered in the management in the unknown cause. And this particular Mullared's meningitis is very important in the entrance point of view. Although again, this question was asked in the last 2 days back, NEET SS also. So this is a recurrent or a chronic meningitis. Sometimes there is a features just of persistent meningitis, or most commonly it is a recurrent meningitis. For example, there is a history of the meningitis The patient was admitted, patient was treated, the patient was recovered, like patient was present with a fever, headache, especially, etc. The CSF was done, which was just some pleocytosis. The hospital managed as a meningitis. Patient improved. Again, after a few months, patient coming with the same symptoms. So there also patient might go to different hospital. They may manage it as a meningitis. Again, some months back, patient having a episode again. So if there are 3 episodes, then it is considered the possibility of molarate meningitis. So this meningitis can be either central or spinal or all together, but it is a benign condition. It is also called as benign recurrent lymphocytic meningitis. So if somebody asks you what is the cause of this molarate meningitis, then the one and only answer should be HSV2. All the entrance questions. Whereas other scientists have also discovered the other etiologies like the varicella zoster PCR have been shown some positivity in some patients also, and the CNS dermoid cysts can coexist, and they may be releasing their content of the cyst in causing this molarate meningitis also. Whereas for all the purposes, entrance purposes, the HSV2 is the only cause of molarate meningitis. And how will you diagnose this? The CSF analysis can be neutrophilic pleocytosis, but they may have a large cells that have been called as the molarate cells. So you can see this picture here. So see this picture here. There is a slide of CSF sample from a 41-year-old woman of the headache, fever, and local rigidity, and she reported she had been a benign aseptic meningitis 15 years ago also. So, and there has been a recurrent headache since 2 years and associated with the herpetic lesions on her buttocks and lower back. So see these cells. So these are actually the monocytes with a bilobed nucleus or a clover leaf nucleus. So these are called as the molarate cells. These are the diagnostic of this molarate meningitis. So what is the treatment? The treatment is acyclovir. Again, the dose is same, 10 mg per kg. The duration is also same, that is 14 to 21 days. So thank you for the quiet listening. We'll take some questions here. How may I contact you personally and what is possible regarding academics? Okay, you can contact me. I am giving my number here. Thank you, and we'll come with the next topic, I think, in the next week, depending on my fate.
Yeah.
Okay.
Thank you so much, sir. It was indeed a very comprehensive class, and your classes are so helpful for all of us. And we appreciate your time and efforts you take to take these classes, sir. We are glad. Thank you so much, sir.
Yeah, thank you.
And thank you everyone who have joined us via Zoom and YouTube. See you in the next session.